and gentlemen, our next speaker is currently an associate professor at National University Hospital, Singapore. She has a special interest in SLE and obstetric rheumatology. She has helped establish specialized clinics at the National University Hospital, combining clinical care, research, and education under one roof.
Dr. Lateef has established several articles and book chapters on different aspects of SLE and serves on an editorial board and a reviewer for many rheumatology journals. Dr. Lateef is currently Chief of Medicine at Woodlands Health Campus. Ladies and gentlemen, please give a warm welcome to Dr. Aisha Lateef.
Good morning. Assalamu alaikum. It's always a pleasure to be back home. This is my hometown where I grew up and did my graduation. So thanks for the invite. I'm supposed to talk about updates in neuropsychiatric lupus, I think one of the most challenging aspects. Before I start, just a quick intro. They mentioned about the Woodlands Health Campus. That's my current baby, due to open in December, still being built. So that's an artist impression, but if you all decide to come to Singapore, we can show you around. Okay, so I'm a clinician by heart. People say I've written articles or research or whatever, but rheumatologists are clinicians first. So we always talk about patients. So what I would do is I'll start with a case scenario, and then we will use that as a base to talk about neuropsychiatric lupus. I understand there are many trainees here, and they may have faced these kind of situations. So a middle-aged woman comes to you. She's known lupus for almost 20 years, has hematologic, neurologic, MSK, serology, multi-system lupus, but currently well controlled after all the treatments. She's in that clinically quiescent, serologically active kind of phase where you see complements, antibodies, but clinically she's fine for a couple of years. And then she comes to you, seems like a flare, multi-system, cytopenias, serologies. Additionally, the family is now realizing that she's very anxious, more headaches, some memory loss. She's only in 50s. She's not your classic 70s where memory loss is normal part of aging. And physical examination did reveal some neck stiffness, but no focal neurologic signs. So what do you all think? Does she have NPSLE as part of her lupus flare? Yes? No? Okay. No one wants to bet on it. Okay, if I say yes, what type of NPSLE does she have? And how would you diagnose her? And how would you treat? So that kind of forms the basis of my talk. Neuropsychiatric lupus, I think most challenging aspect of SLE management. There's a wide variety of manifestations. Severity can range from anxiety headache to status epilepticus. The problem is attribution to SLE remains challenging. Neurologic manifestations can happen in anyone. It's a neurologic disease. But whether this is related to lupus or something else is happening is always a problem. And we will try to address that in a while. Pathophysiology is not one. It's not like always inflammatory. There can be other components. And the full extent of disease burden is still unclear. Different studies have reported estimates which range between 12 to 95%. And why is it so wide? Definitions differ. The inclusion-exclusion criteria, patient population differ. So it's really, the reported incidence and prevalence is so wide and so heterogeneous. To lump it all together and take NPSLE as one disease is really a disservice to the complex phenomena that are happening. Regardless of what kind of disease manifestation or pathophysiology you are dealing with, one thing is for sure, once brain is involved, patients will have reduced quality of life, increased healthcare utilization, more disability, and more organ damage. So it is severe. ACR, as usual, has tried to help us by describing some syndromes and call them NPSLE NPSLE syndromes, neuropsychiatric syndromes, and there are definitions for all of them. So CNS and PNS. But it's more like about describing a case definition, what happens, what diagnostic test you can do. Does not mean that all can be attributed to SLE. It can be that a patient has cerebrovascular disease, but it is in a cerebrovascular disease in a lupus patient rather than a cerebrovascular disease, which is NPSLE. So how do you attribute? Some of these syndromes are very common. So on the left side, you have this table which shows you some of them are very frequent, but they are frequent in general population as well. Anxiety, mood disorders. With current situation in Pakistan, I think 99% of the normal people, you and I will also be having anxiety and mood disorders. Is it NPSLE? Very hard to say. Some are common, some are infrequent. So how do you, one caveat before we move on to attribution. These syndromes were described years and years back. They do not include some of the newly recognized neurological manifestations that we all as clinically know that they can occur, and they are even more bona fide part of the neuropsychiatric spectrum. So CIDP, small fiber neuropathy, PRES, NMO, increasing reports of NMO being associated with SLE, so neuromyelitis optica spectrum syndrome. Again, although they occur in lupus, none of them are specific for SLEs. So then when a patient presents like that, how do you attribute it to SLE? Whether this is the causative link, there is a causative link or not. People have tried to come up with models, like attribution models, putting in multiple variables, things like this particular model used 4 parameters. Temporal relationship between the neuropsychiatric manifestation and SLE diagnosis, whether these are minor or not, whether there are other confounders, and whether they are supporting factors, supporting underlying lupus activity, like presence of other manifestations. And then they put scores on it, and then they come up with a composite score, and using some data regression and all that, they've come up that if using the physician determination as the gold standard, a cutoff score of 7 on this table was found to have a high sensitivity and specificity for attribution. I'm not talking about diagnosis. You have diagnosed that this patient, let's say, has neuropsychiatric, any of those syndromes, whether that is related to lupus or not. This is just one of the attribution models. There are others described in literature. But the fact is, these models can be supportive, but not conclusive. Diagnosis still rely on the judgment of experienced physicians. Now, I beg to differ from the first speaker this morning who said that AI can replace it. I'm a true blue clinician, I disagree. I mean, the AI may support us, AI may guide us, but your clinical acumen is still required. You have to make sense of it and contextualize. That's why still we all have a job. Otherwise, we will be replaced. So using any methodology, any attribution model is still the physician discretion. And only a third of these neuropsychiatric manifestations can be attributable to lupus. Rest of them, gray zone. There's a lot of gray zone where you don't know whether this is really related or not. Okay, but there are features that can support you in your diagnosis or attribution. If there are features like underlying disease activity, it increases the likelihood of that particular manifestation being lupus related. So studies have shown that if you have a high disease activity and you develop a cerebrovascular disease, your hazard ratio is 2.1. So there are other features, and these features have been used on these models. In end, you have to put everything together and use your clinical judgment to say whether this is related or not. And why is it so important to say whether it is related or not? Because that affects your treatment decision. If your non-lupus patient comes in with cerebrovascular disease, you are not going to anticoagulate or immunosuppress that person. But in the context of an APL positive person coming in with a cerebrovascular disease, your treatment change. If a patient with high disease activity comes in with a stroke and you're worried about CNS vasculitis masquerading as a stroke, your treatment and even your diagnostic choices change. And hence it is important to always think about attribution. So I'm not going to read this, but there are factors like disease activity, prior damage, previous or other major NPSLE, presence of APL, as well as non-lupus factors like age, hypertension, dyslipidemia, which can guide you. This serves as guide rather than any, I would say, specific diagnostic tool. So in a nutshell, there are case definitions. There are other things that you need to consider. The pointer doesn't work, but anyway, below in the first box, there are other neuropsychiatric manifestations that you need to consider other than ACR case definition, putting everything together. 2/3 still non-SLE factors, but 1/3 are SLE associated. Whatever it is, they affect the quality of life. So what about what is causing it? Right? You do have strokes, seizures, whatever. Classical teaching was about two major pathways. It's either ischemic, either there is a clot, either in the macrovasculature, like a stroke, or microvasculature, which contributes to cognitive dysfunction. Or it is inflammatory, where antibodies do it. In essence, this is actually an oversimplification, and most likely than not, there's a combination of factors. So it can be ischemic and inflammatory at times, and most of the time it is a multifactorial pathogenesis going on behind the scenes that give rise to that particular manifestation. In addition, there are other non-SLE causes like uremia, like corticosteroids, the therapies that we use that add to the pathogenesis. So not one single factor. Having said that, more and more antibodies are being now associated with neuropsychiatric lupus, and I say associated, which means they are known to be present in serum or CSF of patients with NPSLE. Causative mechanisms or causative link has been only established for a few, and most of them are brain specific. So these are associations. Not everything has a causative link. A lot of them are present systematically, like in the serum, and you can read, I mean, I'm not going to read all that, but there are described associations between antibodies and the manifestations. The ones that I would like to highlight are the ones below, the brain-specific NMDA, antiganglioside, and anti-neurofilaments. And I will elaborate that a little bit more in a while. But more and more, this list is really growing. Similarly, the role of cytokines can't be overemphasized, and research has shown there are lots of cytokines that are associated with neuropsychiatric manifestations. TNF's role is rather controversial. TNF inhibitors can induce lupus-like symptoms, we all know, and TNF inhibitors also can impair the blood-brain barrier, giving access of the systematically produced antibodies to the brain. More likely than not, it is, sorry.
This one for pointer.
Oh, pointer, okay, thank you. More likely than not, it is multifactorial. This is a hypothetical scenario. It's not by no means a confirmed one, but a proposed mechanism or a proposed pathophysiological sequence could be in the blood-brain barrier, you have endothelial cells tightly linked, and then you get endothelial cell activation by specific antibodies, cytokines are produced, leukocytes are infiltrated, They produce immune complexes, further cytokines, and then they kind of go on to activate microglia, and antibodies can also have direct pathogenic effects on neurons. All of this give you treatment targets. So yes, there's a lot going on in NPSLE field, more and more treatments, more and more targets. So watch this space. How do you diagnose? Usually, diagnosis is more about exclusion of anything else, like infections, like any demyelination. So you kind of do CSF imaging for everyone, and then you individualize it depending on what the manifestation is. Judicious use of this whole armamentarium. I'm not suggesting by any means that do everything for everyone. It depends on the patient and the presentation. Tailor it to your circumstances, to your resources. We can only provide guiding principles. Remember that ACR nomenclature can miss other syndromes. The one thing to highlight, do not rely on MRIs. A lot of patients with diagnosed and confirmed NPSLE can have normal MRIs because they are very insensitive markers of picking up the microvascular diseases. They are very inconsistent utility. Common lesions are hyperintense lesions, brain atrophy, but not specific. They can pick up infarcts, transmitted myelitis, but up to 50% of the patients with NPSLE can have normal imaging. So then what do? Advanced techniques. I'm not sure what is available and what is affordable, but there are advanced neuroimaging techniques. I will not go into details. I'm not a radiologist, but just suffice to say, multiple different modalities, DWI, MTI. It took me a while to even try and understand, but they can give you additional information. If you have an experienced radiologist and the facility available, it can be useful. PET scanning is coming up as a very sensitive tool. There are more advanced technologies that often measure the relative concentration of biochemical compounds, and that can give you a differential idea. So don't try and read everything. Only thing to see here that in NPSLE, they are less. So this is lupus patient, and you can see they are missing a lot of bundles and stuff, basically showing you that there are alterations in microarchitecture and micrometabolism in lupus patients that can only be picked up by these advanced technologies. Having said that, I would say that they are still not very specific and not very well established. There are more studies required to determine the prognostic value of these abnormalities. I mean, you can have fancy all the color-coded things, but what does it mean actually? We still need more data about it. In a nutshell, you have neuropsychiatric event, you did everything, you diagnosed, you treat the confounder, you treat symptomatically, but you do need lupus-specific therapies if you are thinking that this is lupus-related. Anticoagulate if there's ischemic component. The thing to highlight is about inflammatory pathway. So if there is an inflammatory component to it, how do you treat? Unfortunately, we do not have RCTs, and unlikely that we will ever have. We use glucocorticoids, but be aware, we all know that corticoids is not good, and we all have a love-hate relationship. Life and organ saving, but long-term consequences. So treat, give steroids, but try and taper. Cyclophosphamide was shown to be efficacious in just one RCT, and then it became standard of care for years. The pendulum is shifting. More and more drugs are now being used. This is data from a single center just published this year. And about 24% of their patients had NPSLE. Attribution, they think it was 70% was in inflammatory, combined in 30%, which is inflammation and ischemia. Treatments, whole list. Despite limited evidence, almost everything was used. People are extrapolating from lupus nephritis trial. What do you do when you don't have? You use the nearest available data point. Lupus nephritis trial, so the concept of induction remission. methylprednisolone, cyclophosphamide, MMF, everything is on the cards. Generally, my own practice for severe cyclophosphamide, otherwise MMF, Ritax has its own use. The other thing which I just wanted to highlight is the concept of other treatments, so newer targets, antithrombotic, but there's this concept of blood-brain protective agents that's coming up. ACE inhibitors have a role because they help with the blood-brain barrier. In addition to immunosuppressants, there's concept of neuroprotective agents. Okay. There are newer targets and non-selective treatment targets as treatment adjuncts that are also coming, like serotonin receptor inhibitors and other non-immunomodulator therapies. Running out of the time, but there are this concept, so neuroprotective agents, they target multiple mechanisms of especially the pathways. There are candidate drugs like calcium channel blockers, sodium channel blockers, there is potential use in lupus. So NMDA blockade, if you remember, there was an anti-NMDA antibody. So NMDA blockade with glutamate inhibitors might provide protection in NPSLE. There's animal data and there are ongoing studies. There are unresolved issues. What about the immunosuppressive therapy for manifestations which have a more doubtful inflammatory basis? And treatment decisions should be individualized, taking into account overall assessment, severity, and evolution. There are factors that can push you towards immunosuppressive therapy in a patient we are not sure, but in the end, putting everything together, it is your clinical judgment that has to come into play. I ran out of the time, so basically just different pathways and different suggested algorithms, and EULAR recommendations, pretty much the same what I have said just now. Immunosuppression for inflammatory, antithrombotic, you might need them all in combination. So that's all I have, and I would like to invite all of you to come to Singapore next year. We are hosting APLAR in August, so a little bit of advertisement here. And I'm happy to answer any questions if you have.
Ladies and gentlemen, we haven't had a question and answer session for Dr. Suleiman's talk, for Dr. Bina's discussion, and of course, Dr. Aisha Lateef's discussion. We also have we have also arranged refreshments for our guests, which are available toward the back of the hall. In case you feel the need, please help yourself. That way you can enjoy your refreshments, and we'll be carrying on with the question and answer session simultaneously.
It's my question to Aisha. The list of drugs she mentioned for neuropsychiatric lupus contains cyclosporine A, and actually preparing myself for Behçet's disease, I find it is contraindicated to be given in at least neurobehçet because it seems to cause more CNS toxicity. So I don't know if this applies also here for SLE, neuropsychiatric.
There are always concerns. Even when you use cyclosporine for any indication, we use it for lupus nephritis, but it can cause interstitial nephritis. And similarly, it can cause neurologic issues, especially peripheral neuropathy. You just have to look at your patients and individual circumstances. That was a single center data. Personally, I'm yet to use calcineurin inhibitors for neuropsychiatric lupus. Generally, they get the bigger guns like cyclophosphamide and rituximab. But in that particular study, they did report the use of calcineurin inhibitors as well. Yeah. Yes, one has to be cautious because there are side effects which can be neurologic manifestations for all the calcineurin inhibitors. But sometimes you just have to balance the pros and the cons. I personally don't think it's contraindicated. If we want to look at the issues that can happen with a drug, then we can't use calcineurin inhibitors for lupus nephritis as well. They can cause interstitial nephritis. You just watch. I mean, if you put someone on cyclosporine, you watch their creatinine. You keep asking them whether they have tingling in their arms, whether they are forgetting things. It's about balancing the risk and the benefits.
Yeah, at least for Behçet's, neurobehçet, it is strongly
Yes,
recommended against. Thank you.
Yeah. Thanks for reminding us.
Dr. Aisha, I've got a question regarding the modalities like MRV and MRA, where do you place them in advising them in patients with lupus cerebritis? Because sometimes the patients comes with typical history of fits, and we think that this is probably lupus cerebritis, and we go for an MRI, and MRI shows some atypical changes, and we're saying this is cerebritis. But sometimes our neurologists say, why don't you go for an MRV? And we go for an MRV, and there's a cortical vein thrombosis, which was not picked up in an MRI. And that totally changed the modality, that we need to think that this is probably APLA or what we need to go for. And so where do you think in your clinical practice, do you advise MRV in all the patients who present with fits?
So we don't. I mean, it depends on the presentation. So if presentation points towards a vascular event, be it arterial or thrombosis, then you image the vessels. You are looking at venous, you do MRV. You are worried about arteries, like aneurysms or vasculitis, you do an MRA. Having said that, MRA is not very sensitive for small vessel vasculitis. Then you need 4-vessel angiogram, the invasive traditional 4-vessel angiogram. So it all depends. For vasculature, MRA, MRV, or 4-vessel angiogram. But if you are worried about the subtle inflammation going on that you are not picking up on your traditional MRI, that's where all these newer modalities, which are looking at the differential expression of all these biomarkers and whatever they are using, that's where these imaging modalities come in. But vessels, MRV, MRA, I don't do it for everyone, simply because I think that's a bit of over-investigation. It depends on your clinical context. If a patient is coming with, let's say, seizures, right, and then your MRI is clear, but at the same time you're worried about pressures in the brain, or the patient has APLs, then it just makes sense to look at the vessels as well. Yeah, so it's all about the clinical manifestations. I didn't go into detail, but if you are worried about inflammatory component, then you definitely need to do a CSF evaluation in each of these patients as well.
Thank you.
Assalamu alaikum, Dr. Aisha. Thanks for a nice talk. My question is related to the role of serology, and especially in terms of anti-ribosomal P protein antibodies. Recently, I have a patient who has been a young girl being treated for depression, actually mutism. She was always mute, doesn't want even to communicate. She had vitiligo as well and hypothyroidism. Someone got ANA done, which was positive. Came to me, I got ENA profile done. The only antibody positive was ENA, is ribosomal P protein, 3+ positive. Nothing else was positive, even complement, dsDNA, everything was negative. Antiphospholipid antibodies negative. Brain imaging shows mild atrophy. I started the patient with hydroxychloroquine and low-dose corticosteroid. After 3 months, she did amazingly well, and she started communicating and doing everything. So how often you see this, and what is the relation between anti-ribosomal P protein and neuropsychiatric?
Anti-ribosomal P is quite specific for neuropsychiatric lupus. Unfortunately, we don't have it available in Singapore. We have to send it out, and we do send it out in patients where the diagnosis is rather unclear. Strong association. Whether I would use only anti-ribosomal P positivity as my diagnostic basis for NPSLE, a little bit challenging to say, because that's one of the antibodies only. You do need multiple other supporting events before you can attribute, because if you go to my attribution model, I know that's more like a research tool, but if you go to the attribution model, that patient of yours might score very low. So we all have anecdotes. I have a very similar patient, deaf and mute, young man, coming to me for rashes and positive antibody, and I treat him for that, and his hearing and cognitive function improve. So we all have anecdotes everywhere where things have just been wondrous for patients. But can we use that as evidence for recommendations? I would hesitate, right? So anti-ribosomal P, yes, very specific, but in the right context. I'm a bit at a loss to advise you about your patient. Anyway, you have treated her and she's doing well. As clinicians, we always go beyond just what the evidence tells us, because evidence is the prerequisite for you to make decisions. In the end, you are the physician, and in discussion with your patient, you make decisions about that individual person. Evidence can only guide you. So in a nutshell, yes, it's specific. Yes, it's useful in the right clinical context.
Dr. Salman and Dr. Bina Hamid. So if you have questions directed to these two speakers which have not had a chance to respond, kindly come forward and ask your questions, and we'll continue the session subsequently. Aisha, you are relieved now. You can sit.
Thank you.
Thank you.
So yes, my question is from Dr. Suleiman. I am Dr. Tariq Iqbal from Afridi Medical Complex in Peshawar. Nice presentation by the speakers. My question is regarding antiphospholipid antibody syndrome. I recently treated a case last month, and my diagnosis was probable CAPS with recurrent DVTs, but had popliteal vein involvement, and then IVC, and then intracardiac thrombus with arthritis and thrombocytopenia, triple antibody positive. So I went aggressive and started with pulse steroids and then oral steroids. And because this just last month, and we are talking about IVIG because they cannot afford, and then rituximab as per the registry studies. So my question is that in regards to the criteria, new criteria that we're talking, is there a time limit? Like they talk about 1 week diagnosis, the multiple thrombotic presentation happening over a period of 1 week, versus we can be a little flexible in that. And secondly, in our Pakistani setup, how do we adjust warfarin doses, talking about APS in itself, because INR cannot be done so frequently by our patient population who are away from big centers.
I think it's a good question. So what you describe is that a potential catastrophic APS in a limited duration of time, and the patient had some inflammatory arthropathy type symptoms, and you treated with steroids. But I think when it comes to anticoagulation, definitely that needs to be in place rather than purely relying on steroids or immunosuppression. Warfarin, initially, I know it's a challenge here, and I have faced this problem quite a lot here in Peshawar and Islamabad. Initial loading dose, and obviously you need to have weekly monitoring till the INR is between 2 and 3 for low risk patients. But if it is a recurrent persistent problem with the frequent episodes of thrombotic events, then some argue that between above that level up to 3.5 or 3 to 3.5 of INR is advisable. So that's what I would suggest. But in terms of the criteria, I think the weak limit is only for catastrophic APS, where there is multiple organs involvement. But beyond that, I think we see these patients from time to time, and a time bar probably is not possible always, and you have to take into clinical context, what the patient has, and how they are progressing with the treatment that you have offered. So it's something that I look after these patients with a open mind, and treat them as I see them and I find them clinically and immunologically, and then how they actually respond to the treatment and the various aspects of their care.
Yeah, so we did give her the anticoagulation. Patient was obese, more than 100 kilograms, so we gave the divided dose, started with the bridging therapy with Clexane and then warfarin, and brought it up close to between 2.5 and 3, and then discharged home. But that was a difficult situation for, I think, most of our patients who cannot do INRs regularly. Then I've seen on the same trajectory patients with APS who are just on warfarin, and they're taking it because they just cannot do INRs. And the INR, when we do, like maybe in 2-3 months, they're just sitting under 2.
Well, I was using my office WhatsApp for patients living in Banu or Diyai Khan or, those areas. They used to send me the INR. They used to do there in their hometowns and send me the INR, and I used to adjust it that way. So it is a challenge, and certainly not the artificial intelligence will apply here. A lot of things do not apply to us. We are different, so in some ways. But yeah, it can be challenging, and that's where our role is as physicians and rheumatologists.
Yes, great. Thank you.
Thank you.